అక్కడే పెట్టి స్ప్రే కొట్టు.
Okay, so today we will talk about orthopedics. Discuss the orthopedics
Sure.
MCQ. Okay. Stress factor. First question is stress factor occurs most commonly in metatarsal, metacarpals, calcaneum, talus. And the answer will be metatarsals. So stress factors develop from overuse, high impact sports like distance running or basketball. Most stress factors occur in weight bearing bones of the foot and lower leg. Weight bearing bones of foot and lower leg studies shows that athletes participating in tennis, gymnastics, dance, basketball, track and field are all at high risk for stress factor. So it most commonly occurs in metatarsals. Seen due to imbalance between load and resistance of the bone. So this fracture is simply due to physical stress, and this stress is obviously transmitted to metatarsals, and there may be fractures in the metatarsals due to physical stress caused by high impact high impact sports or high impact stresses, especially occurs in sports, which occurs in sports. So basically there are two types of stress factors. One is increased load, normal resistance. So load is abnormally high. Load is abnormally high, that is why there will be stress factor. So load is abnormally high, but the resistance of the bone is normal. So that is called fatigue type of stress factor. Number two is normal load is normal, but resistance of the bone is decreased. Resistance of the bone is decreased. Insufficiency type of stress factor. So two types of stress factors, and this may occur maybe due to deficiency of calcium or phosphorus. This may also occur this insufficiency type. But fatigue type occurs due to increased load, abnormally increased load, which is much more than the capacity of the bone to hold. So examples of stress factors, it can be in the upper extremity, olecranon fracture can occur. In lower extremity, metatarsal, second metatarsal mostly get affected than third metatarsal. And most common is in the lower extremity and specifically to metatarsal bones. So this is about stress factor. Next is runner's fracture occurs in which bone? Fibula, metatarsal, tibia, calcaneum. Fibula. The most common site of runner's fracture is distal shaft of fibula. Distal shaft of fibula. Here. Those who runs or sprint. Okay, next question. Fracture and dislocation of lateral clavicle. Fracture and dislocation of lateral clavicle occurred. The best treatment is Figure of 8 splint, open reduction, normal sling, surgical repair. Now this question can come in case of case form, but this, here it is little bit direct question. Clavicle fracture and dislocation. Lateral clavicle is fractured and dislocated. So the treatment is, best treatment is, and the answer will be surgical repair. Since best treatment for lateral third fracture, lateral third of the clavicle fracture and dislocation of the clavicle is asked, fracture and dislocation of the clavicle is asked, the best choice will be surgical repair. Distal third of the fracture of clavicle accounts for 15% of clavicular fracture. Now, non-displaced fractures of distal clavicles are splinted and treated symptomatically with ice, analgesic, and slings. Non-displaced fractures. So, if there is only fracture, we go for non-displaced fracture of distal clavicle. That also not distal clavicle. Splint is used, splint is applied, splint and treated symptomatically. That is ice. That is ice, analgesic, sling. Dislocated fractures of the distal third requires surgical intervention. Dislocated fractures of the distal third requires surgical intervention because of the rupture of coracoclavicular ligament. And if displaced fracture is treated conservatively, it may cause non-union. There will be not proper union of the two broken ends. So distal third requires surgical intervention. So in this case, we need to go for surgical intervention, surgical repair, due to the fact that there may be rupture of coracoclavicular ligament. Okay. So next question: avascular necrosis can be a possible sequel of fracture of all of the following bones except femur, neck, scaphoid, talus, calcaneum. So avascular necrosis can be possible sequel of fracture of all of the following except which bone? Except calcaneum. So avascular necrosis, let's see, this is the typical picture of avascular necrosis. Head of femur, fracture, common sites of avascular necrosis. Head of femur, fracture neck, femur, posterior dislocation of hip. Then head of femur, can have avascular necrosis. If avascular necrosis is located in the proximal pole of the scaphoid, then fracture occurs or due to the fracture through waist of scaphoid fracture. If avascular necrosis occurs in the body of talus, it may occur due to the fracture through neck of talus. If avascular necrosis is located in the lunate, then it may occur due to dislocation. Which of the following is a static stabilizer of shoulder joint? Supraspinatus, infraspinatus, negative pressure in the glenoid cavity, and subscapularis. So static stabilizer of the shoulder joint. We know all these fours are stabilizer. But those stabilizer of shoulder joints can be divided into two parts. One is static type, one is dynamic types. So static is negative pressure in the glenoid cavity. Like glenoid labrum, glenohum ligaments, negative pressure in the glenoid cavity. These three are static, they do not move. And dynamic stabilizer includes supraspinatus, infraspinatus, all these muscles. All these muscles are dynamic stabilizer. All these muscles are dynamic stabilizer. Supra-infraspinatus, teres minor, subscapularis. So shoulder joint is the most mobile joint of the body. Being the most mobile, it is also stable at its position. Most mobile joint of the body. Where mobility, highest mobility. Right? Highest mobility, lowest stability. Highest mobility, lowest stability. So this can be due to the following factors. First of all, SITS muscle. What is SITS muscle? S for supraspinatus, infraspinatus, teres minus subscapularis. This sits muscle, SITS muscle, is also known as rotator cuff. Rotator cuff. SIT, not subscapularis. Supraspinatus, infraspinatus, and teres minor. These three inserts on greater trochanter. Greater trochanter. Subscapularis inserts on lesser trochanter. Tendon passes in intertubercular groove is long head of bicep brachii. So that's different. So this is the insertion. This is the insertion. So these are the stabilizer which stabilizes the joint. As it is told, it is also stable at its position. Who stabilizes? These are the stabilizer. Okay, next question. Supraspinatus injury leads to which of the following? Frozen shoulder, winging of scapula, cannot abduct, inability to abduct, inability to adduct. So the answer will be inability to abduct. Now, in case of supraspinatus injury, abduction is restricted. Function of rotator cuff muscle. Supraspinatus, first of all. It assists deltoid in abduction of the arm by fixing the head of humerus against the glenoid cavity. Infraspinatus and teres minor, lateral or externally rotates the arm, stabilizes the shoulder joint. While subscapularis, internal rotation. These are the functions of rotator cuff muscle. Not only in orthopedics, but also these things are very, very important for anatomy. Shoulder joint. Very important for anatomy. Okay, next, in anterior dislocation of shoulder, which nerve is commonly affected? Axillary nerve, radial nerve, ulnar nerve, median nerve. In anterior dislocation of the shoulder, which nerve is commonly affected? So the answer is axillary nerve. The shoulder is most frequently dislocated joint. It moves almost without restrictions but pays the price of stability, means at the cost of stability. Shoulder's integrity maintained by glenohumeral joint capsule, cartilaginous glenoid labrum, and rotator cuff muscles. And as we studied just now, the stabilizer, static stabilizer, and the dynamic stabilizers. Anterior dislocations occur in as many as 98% of cases. Anterior displacement of the humeral head is most common dislocation seen by emergency physician. Okay, so an inferior shoulder dislocation is the least common. Inferior shoulder dislocation is the least common. Because now the condition is called luxio erecta, because the arm appears to be permanently held upward or behind the head in a fixed abduction. So it is caused by hyperabduction of the arm that forces the humeral head against the acromion. Now these are some of the dislocation and fractures in which corresponding nerve injury occurs. For example, in anterior shoulder dislocation, usually axillary nerve is affected. In surgical neck humerus fracture, again axillary nerve. So axillary nerve is affected in anterior shoulder dislocation and surgical neck humerus dislocation. Humerus shaft fracture. In humerus shaft fracture, radial nerve get dislocated. The radial nerve get affected. Supracondylar fracture, anterior interosseous nerve is affected, and also median nerve, but anterior interosseous is more affected than median. Cubitus valgus, tardy ulnar nerve palsy occurs. Ulnar nerve palsy occurs. Medial condyle humerus fracture, again ulnar nerve is affected. Okay, next question. In a man lifting up suitcase, posterior dislocation of glenohumeral joint is prevented by deltoid latissimus dorsi, coracobrachialis, shorted of bicep. In a man lifting up the suitcase, posterior dislocation of glenohumeral joint is prevented by which muscle? So the answer will be coracobrachialis. Glenohumeral joint is the most important joint of shoulder complex. Glenohumeral joint. It is a synovial ball and socket articulation between the head of the humerus and glenoid cavity of the scapula. Movement at this joint includes flexion, extension, abduction, adduction, medial rotation, lateral rotation, circumduction. Posterior dislocation of glenohumeral joint would be prevented by the muscle which originate posteriorly and inserted anteriorly. So the net vector of pull of this muscle would be anteriorly opposing the posterior dislocation of the shoulder joint. So coracobrachialis muscle originates from coracoid process of scapula and inserted at medial aspect of shaft of the humerus. And coracobrachialis is the muscle which prevents posterior dislocation of glenohumeral joint. Okay, so this is the table of origin and insertion of muscles which are present surrounding the shoulder joint. So first of all, deltoid. Number 2, coracobrachialis. Number 3, latissimus dorsi. Number 4, biceps. So 4 muscles. Deltoid is originated from anterior border of the clavicle, middle fibers, lateral border, posterior fibers, lower lip of crest of spine. Coracobrachialis and getting inserted into deltoid tuberosity of the humerus. Coracobrachialis, coracoid process of scapula. Latissimus dorsi, posterior 1/3 of the iliac crest, lumbar fascia, thoracic vertebra, lower 4, inferior angle of scapula and spine of lower 6 thoracic vertebra. And inserted into floor of bicipital groove. While biceps, long head, supraglenoid, short head, coracoid process of scapula. Tuberosity of radius is the insertion point. So classical clinical feature of posterior dislocation of shoulder is arm is held in medial rotation. This is very important line and is locked in that position and an examiner cannot externally rotate it. This is the clinical diagnosis of posterior dislocation of shoulder. So next question. Which of the following test of shoulder dislocation is verified by just looking at the axillary fat folds? Very important. Dugas test, Calvert test, Hamilton and Bryant's tests. Dugas test, Callaway, Hamilton, Bryant's test. And the answer is Bryant's test. In Bryant test, the axillary fat fold is found to be displaced inferiorly. Axillary fat fold of the side of the side of the dislocated shoulder will be found to be displaced inferiorly if compared to the normal side. Dugas test. In Dugas test, what happens? In Dugas test, if the patient is is asked to put the hand on the opposite shoulder, then bring the elbow close to the chest, he or she cannot perform it. That means it's a positive one. Callaway test, check for circumference of dislocated shoulder and compare it with normal side. Compare it with normal side. Circumference on dislocated side will be more than that of normal side. And Hamilton ruler, if a ruler is placed on an upper arm, if two ends can easily touch the acromion and lateral condyle in a straight line. In normal person, it will not be possible due to humeral head prominence. So all these four tests basically are used to diagnose shoulder dislocation. Okay, these are the four tests: Bryant's, Dugas, Callaway, Hamilton ruler. Hill-Sachs lesion, hip joint dislocation, elbow dislocation, shoulder dislocation, jaw dislocation. Hill-Sachs lesion is shoulder dislocation, is found in shoulder dislocation. It is called Hill-Sachs fractures also. It's a cortical depression in the posterolateral head of humerus bone. This is the posterolateral head. This is the posterolateral head is here. So here, this is the anterior side. This is from the posterior side. See, posterolateral. Okay, posterolateral head. This is the head, right? So posterolateral head of humerus bone. It is seen in the anterior shoulder dislocation. What happens? Anterior shoulder dislocation, the shoulder rotates like this, and while posterior side rotates like inside, means this side is compressed by the glenohumeral joint, and there can be Hill-Sachs lesion due to forceful impaction of the humeral head against the anterior inferior glenoid rim. This is the glenoid rim. So when this is the posterior, this is the anterior. So and in anterior dislocation will lead to like this. Like this, right? Anterior dislocation occurs. And when anterior, this is the posterior, this is the anterior. So when anterior dislocation occurs, the posterior head of the humerus forcefully hit the anterior inferior glenoid rim. And this damage occurs. So reverse Hill-Sachs lesion is due to the posterior shoulder dislocation. Again, it is same, just opposite. And Bankert lesion is avulsion of the anterior glenoid labrum. Avulsion type of fracture, Bankert. Okay. So next question. Colles fracture, which of the following, regarding Colles fracture, which of the following tendons likely to rupture? So flexor pollicis longus, pollicis brevis, extensor pollicis longus, extensor pollicis brevis. And the answer will be pollicis longus, extensor pollicis longus. So Colles fracture is the fracture of distal radius, right? Distal radius at the corticocancellous junction with dorsal displacement of distal segment. Dorsal displacement of distal segment. Here we can see Colles fracture in different form, schematic form, and also X-ray images. Very important for IBQ also. Orthopedics IBQ very important, and orthopedics was number of questions was increased last time in the 2019 December. A lot of question came from orthopedics. So mechanism of injury: fall on outstretched hands. Colles fracture occurs when the person fall on outstretched hands with wrist in hyperextension. So outstretched hand with wrist in hyperextension. This is very important point. Even a question comes, how is the mechanism of injury, or it may be included in the case. The person was, or the child was fell down on outstretched hand with the wrist in the hyperextended wrist with a hyperextended wrist. So you can understand this is Colles fracture. So what are the complications of Colles fracture? Joint stiffness is the most common one. Second most common is malunion. Sudex osteodystrophy also occurs, and rupture of extensor pollicis longus. Typical our question. Rupture of extensor pollicis longus tendon, less common complication, usually seen after 4th week of injury. Less common, but it occurs. It can occur, obviously. So extensor pollicis longus tendon may rupture in Colles fracture. Okay, Kienbock's disease is avascular necrosis of lunate. Lunate, so it is the breakdown of lunate bone, a carpal bone in the wrist. You know that it articulates with the radius in the forearm. Now, avascular necrosis with fragmentation and collapse of the lunate. This has classically been attributed to arterial disruption. So what happens? In Kienbock's disease, arterial disruption so first of all, avascular necrosis of lunate wrist bone, and it may lead to fragmentation of lunate. It may lead to fragmentation of lunate. And leading to arterial disruption. Actually, this fragmentation only cause arterial disruption. It compresses the surrounding arteries. In fact, later there may be venous congestion with elevated interosseous pressure. So all these will cause fragmentation, venous congestion. All these will lead to elevated interosseous pressure. Pressure between bones. Pressure between bones. Interosseous pressure may increase. Okay, so Monteggia fracture. Monteggia fracture is a fracture of distal radius with dislocation of head of ulna. Fracture of the proximal third of the ulna with dislocation of head of the radius. fracture of the distal third of the ulna with the dislocation of head of the radius, fracture of the proximal one third of the radius with the dislocation of head of radius. So the answer is fracture proximal third of ulna with dislocation of the radial head. Fracture of the proximal of ulna. You see, this is the proximal ulna. Proximal ulnar fracture with dislocation of the head of radius. Dislocation of the head of radius. Radial head dislocation. So this is a combination, Montegia. Two things has to be there. Radial head proximal ulnar fracture. Actually, this is the first process. It leads to radial head dislocation because it compresses or it pushes the radius. And radius, what happens as it pushes in the proximal part of the radius, because the fracture occurred in the proximal ulna, the head get dislocated, radial head get dislocated. There will be no such breaking, but there may be a little fracture in the radial this portion. But what majorly usually occurs is radial head get dislocated. So two things, two features: proximal ulnar fracture with radial head dislocation, proximal ulnar fractures with radial head dislocation. And this proximal means one third of the ulna, means the first third. If we divide the ulna into three parts, then the first part from the proximal. Okay, so Montegia fracture of, as we started, fracture of proximal third of the ulna with the dislocation of the proximal radioulnar joint. Okay, so posterior interosseous nerve, which nerve is affected? Posterior interosseous nerve is damaged in case of Montegia. This is another MCQ, very important. You must know which are the nerves that are getting affected in respective fractures, especially the big major fractures. So Montegia fracture occurs on fall on outstretched hand with the forearm in excessive hyperpronation injury. Now this outstretched hand is quite common, but here you see excessive hyperpronation injury. So the person or the child may be fall on outstretched hand plus hyperpronation forearm, hyperpronated forearm. In Colles fracture, how was the mechanism? Outstretched hand with hyperextended wrist. Hyperextended wrist. This was the Colles fracture. Hyperextended wrist. But Montegia, hyperpronated forearm. Hyperpronated forearm. Outstretched hand is common in both the fractures, Montegia and Colles. Okay, next, Galeazzi fracture. Galeazzi fracture is fracture of the distal third of radius and dislocation of distal radioulnar joint. Now we see this is completely opposite to the Montegia. In Montegia, ulna is the first thing. Ulna fracture is occurring, and then radial head is dislocating. Now it is in the proximal. Montegia is completely occurring in the proximal area. Proximal area. And starting from starting from ulnar fracture to radial head, leading to radial head dislocation. But in Galeazzi, it's starting from radial fracture. Starting from radial fracture, leading to radioulnar joint dislocation. Leading to radioulnar joint dislocation. And whole thing is occurring in the distal. Distal radius is fracturing. Distal radius fracture is occurring, leading to dislocation of radioulnar joint at distal portion. Distal radioulnar joint dislocation is occurring. Everything is in the distal. And here the proximal. In Montegia is proximal. Galeazzi is distal. Everything is in distal portion. Okay. So next question, injury in the radial groove lead to. Another thing is that isolated ulnar shaft fracture occurs sometimes. They are most commonly seen in defense against blunt trauma, that is called nightstick injury. And such an isolated ulnar shaft fracture is not a Montegia, but it's a nightstick fracture. So do not confuse that nightstick fracture also includes ulnar shaft fracture. Ulnar shaft fracture. But it is not Montegia, because there will be no radial head dislocation also. There will be no radial head dislocation. And it's not also not mentioned in nightstick fracture that proximal ulnar fracture is occurring, or distal ulnar or middle ulnar, middle third of the ulna is getting fractured or not. It's not mentioned anywhere in the ulna, in the shaft of the ulna, anywhere in the shaft of the ulna. And only ulnar fracture is present in nightstick fracture. It's quite different from Montegia. It's not at all same. Okay. Okay. Next question. Injury in the radial groove will lead to wrist drop, Bennett fracture, Skear's thumb, and mallet finger. So injury in the radial groove, and the answer is Bennett fracture. Bennett fracture dislocation is particular articular fracture of first metacarpal base. Fracture of first metacarpal base with trapezium metacarpal joint. This is the Bennett fractures. At the base of the metacarpal, there lies the radial groove. And this will be the most suitable answer for this question. So Bennett fracture, we will go for Bennett fracture. Wrist drop is different, completely different due to injury to the radial nerve. Skear's thumb is sprain or rupture of ulnar collateral ligaments due to the forceful radial and palmar hyperabduction. So ulnar collateral ligament rupture and forceful radial and palmar hyperabduction of the thumb because of the snow skiing accident, especially in snow skiing accident. But if we leave this also, the mechanism, forceful radial and palmar hyperabduction of thumb, Skear's thumb. Skear's thumb, remember also, this is also important, Skear's thumb. Hyperabduction of thumb, hyperabduction. Mallet finger flexion, it's a flexion deformity of the distal interphalangeal joint. Mallet finger is the flexion deformity of the distal interphalangeal joint due to avulsion of the extensor tendon of distal phalanx. This is mallet finger. Okay. Now radial groove or anatomical snap box. The contents are written here. Radial artery, tendon of abductor pollicis longus and extensor pollicis brevis. Scaphoid bone, the floor of the scaphoid. Superficial cutaneous branch of radial nerve. The partial tear of supraspinatus. Okay, next is winging of scapula and frozen shoulder. So winging of scapula occurs due to long thoracic nerve injury or leading to palsy. Long thoracic nerve palsy, winging of scapula. This is typical of winging of scapula. Affected region, scapular winging. Mild deviation occurs here and protraction of the unaffected. Unaffected spine will be unaffected scapula is protracted. Frozen shoulder, also known as adhesive capsulitis. Adhesive capsulitis in frozen shoulder. What happens in this adhesive capsulitis? All range of the motion is restricted. So all motions are restricted. Associated with diabetes mellitus, hyperthyroidism, Dupuytren disease, cardiac disease, etc. So this is about frozen shoulder. Okay, next question. Which of the following doesn't indicate ulnar nerve injury? Which of the following doesn't indicate ulnar nerve injury? Clawing of medial 2-digit Froment sign is present, abductor pollicis longus palsy, loss of sensory supply of medial little finger and medial half of the ring finger. Okay, so answer is abductor pollicis longus palsy. Abductor pollicis longus muscle is innervated by posterior interosseous nerve. Abductor pollicis longus muscle, this muscle is innervated by posterior interosseous nerve. So it is a continuation of deep branch of radial nerve only. Deep branch of radial nerve. After it passes through the supinator muscle. Froment sign test for palsy of the ulnar nerve. Specifically, the action of the adductor pollicis. So Froment sign test for it is done for palsy of the ulnar nerve, specifically the action of adductor pollicis. With ulnar nerve palsy, the patient will experience difficulty in maintaining a hold, and will compensate by flexing the flexor pollicis longus of the thumb to maintain grip pressure, causing a pinching effect. Injury to the ulnar nerve at different levels causes varying motor and sensory deficit. Okay, so which of the following doesn't indicate ulnar nerve injury? Abductor pollicis longus palsy. Because abductor pollicis longus muscle is innervated by posterior interosseous nerve coming from deep branch of radial nerve and not ulnar nerve. And other things are related with ulnar nerve injury, other options. Okay. First sign of Volkmann injury. The first sign of Volkmann ischemia is pulselessness, pallor, paralysis, pain. And the answer is first sign of Volkmann ischemia is pain. Clinical feature of Volkmann ischemia is pain out of proportion to physical examination findings, pain on passive stretching first sign, pressure increased, pallor, pulselessness, paresthesia, paralysis. Nerve involved in VIC interosseous nerve more than median nerve. So also both of them get involved, but this is more commonly involved. And pulselessness is a late sign and is unreliable for diagnosis of compartment syndrome. Okay, next question. A pregnant woman a pregnant woman A pregnant woman aged 30 years after trauma, feeling tingling pain. Years after trauma, feeling tingling pain and numbness at the tips of thumb, index finger, and middle finger. On examination, doctor presses between the wrist joint for 30 seconds, and the patient develops more pain at the tip of the middle index and thumb. So diagnosis: carpal tunnel, cubital tunnel, tarsal tunnel, pronator. So wrist joint for 30 seconds and patient develops more pain at the tips of the middle index and thumb. So it has to be carpal. Wrist joint, that means carpal tunnel is being pressed. Carpal tunnel syndrome it is also known as actually pronator syndrome, same. But anyway, we will, as carpal tunnel word is there, we will choose this only. First of all, median nerve is involved. First of all, median nerve proximally compressed beneath ligament of ligaments and bicipital aponeurosis or origins of pronator teres or flexor digitorum superficialis. And you see, another point is on examination wrist joint. So carpal tunnel is there, and there will be tingling sensation, tingling pain, numbness at the tips of the thumb index and middle. That means coming from median nerve. These are involved. These are involved. That means median nerve is involved. And median nerve is involved in carpal tunnel syndrome. Means thumb, index, and middle finger is involved in median nerve injury or pressure, or when median nerve is affected. And cubital tunnel, ulnar nerve is affected. Ulnar nerve at wrist, cubital tunnel is different. Tarsal tunnel, and another thing is that between the two heads of flexor carpi ulnaris or arcade of Struthers are involved. And especially if this tingling pain and numbness will not be present at the tips of the thumb, index, and middle finger. Instead, it may be present in the ring finger and in the little finger. Okay. Okay. Next is tarsal tunnel syndrome, posterior tibial nerve, thoracic outlet syndrome, lower trunk of brachial plexus and subclavian vessels. Okay. So median nerve is compressed at the wrist, resulting in numbness or pain. Finkelstein test is done for compound palmar ganglia, carpal tunnel syndrome, decurvent tenosynovitis, tennis elbow. So the answer is decurvent tenosynovitis. Finkelstein test is one way to determine if there is tenosynovitis in the abductor pollicis longus and extensor pollicis brevis tendons of the wrist. These two tendons belong to the first dorsal compartment. And Finkelstein test is used to diagnose decurvent tenosynovitis in people who have wrist pain. To perform the test, the physician grasps the thumb and the hand is ulnar deviated sharply. If the sharp pain occurs along the distal radius, it's indicative of tenosynovitis. So decurvent tenosynovitis. And which test? Finkelstein test. You need to remember this orthopedic test name. Okay, and the mechanism also, sometimes they give the picture as well. Although some of the pictures we have also given. And especially the the examination, how the examination is done. That is also important because they come in cases. They come in cases. And they may ask which test is this, for which purpose, you need to know two things. Always need to know two things. The involved structures, and if there is involved structure is muscle, then especially which nerve is affected. Involved structures, clinical features like pain and tingling sensation and etc. Especially which pain, wrist pain, and how the test is done. Deuterian contracture is associated with all except seen in cirrhosis, involves the ring and little finger. Tabletop test is negative and clostridial collagen is for resolution. Deuterian contracture is associated with all except tabletop test is negative. Tabletop test, what is it? It involves placing the palm on the table, which in presence or contracture would turn out to be contracture, which in presence of contracture would turn out to be placing the palm on the table, which in presence of contracture. So if there is contracture, tabletop test, very simple test. The physician asks the patient to keep the palm on the table. Keep the palm on the table with on the surface of the table, fully flat. Fully make the palm flat. If there is any contracture, like this, obviously the patient cannot make the whole palm or a whole hand flat on the surface of the table, and then deuterian contracture can be identified. So deuterian contracture basically in this, the fascia or the tissue lining the underneath the skin of the palm and the fingers become thickened and scarred. Which portion? This portion. This portion is thickened or scarred. As a result, the tissue lining shortens and cause puckering of the skin or limit the ability to straighten the finger joints. That's why if it gets thickened and scarred, what happens? It contracts towards this direction, and the involved finger cannot be straightened. Usually, unpainful condition, usually seen in northeastern European population, causes idiopathic. Most affected finger is ring finger and then little finger. Thumb is rarely involved, and here also in the picture, it is the ring finger. Yeah, ring finger. So there is no such definite treatment, but clostridial collagen is excellent result, can give you excellent result and becoming method of the treatment for this condition. So tabletop test is the test for deuterian contracture, and it has to be positive in order to diagnose deuterian contracture. Okay, next question. Anterior cruciate ligaments prevent anterior dislocation of ulna, posterior dislocation of ulna, anterior dislocation of tibia, and posterior dislocation of tibia. So anterior cruciate ligaments prevent what? Prevent anterior dislocation of tibia. Anterior cruciate ligament or ACL stretches from the lateral condylar femur to anterior intercondylar area. Anterior cruciate ligament is critically important because it prevents the tibia from being pushed too far anterior or too much anterior relative to the femur during twisting or bending of the knee. Anterior cruciate ligament is considered as the major stabilizer of the knee. Very important point. And therefore, injury to ACL is the most common knee injury. And if there is ACL tear, reconstruction is commonly done by autograft, meaning the tissue used for the repair is from the patient's body only. And the two most common sources for tissue are patellar tendon and hamstring tendon. So all these points are important for FMG. All these points are important for FMG, and questions can come from all these points as well. The posterior cruciate ligaments PCL stretches from medial condylar femur to the posterior intercondylar area. Medial condylar femur to posterior intercondylar area, and the ligament prevents posterior displacement of the tibia relative to femur. So as the question goes, anterior cruciate ligament prevent anterior dislocation of tibia, while the question may also be posterior cruciate ligament prevents posterior displacement of the tibia relative to femur. Okay, so posterior displacement, posterior dislocation of the tibia is posterior cruciate ligament, PCL. This is ACL. Anterior cruciate ligament, anterior dislocation of tibia. Posterior cruciate ligament, posterior dislocation of tibia. Okay. Okay, next question. So which nerve is injured in the fracture fibula? Posterior tibial nerve, anterior tibial nerve, common peroneal, deep peroneal. Which nerve is injured in the fracture of fibula? So the answer is common peroneal. Common peroneal nerve is vulnerable to injury by direct trauma, and the fracture of fibula occurs. Fracture of fibula fracture of fibula, this common peroneal nerve injury occurs because common peroneal nerve winds around the neck of fibula. So where in whatever way fibula is fractured, the most common, or there is high probability that common peroneal nerve will be injured. Another thing, the manifestation of this nerve injury, that is common peroneal nerve injury manifestation, will be foot drop. Bumper fracture. Bumper fracture is fracture of lateral tibial plateau. This is the typical bumper fracture. It's the fracture of lateral tibial plateau caused by a forced valgus applied to the knee, usually by the impact bumper of a moving car on the lateral side of the knee. While the foot is planted on the ground. This causes the lateral part of the distal femur and the lateral tibial plateau to come into contact, compressing the tibial plateau and causing the tibia to fracture. Main extensor of knee is quadriceps femoris. Main extensor of knee is quadriceps femoris, and it includes Quadriceps femoris basically is the main and only extensor of knee. Others are vastus lateralis on the lateral side of the knee, vastus medialis on the medial side, intermedius lies between vastus lateralis and medialis in the front of the femur, and quadriceps extensor of the knee. That means in the posterior aspect. It produces locking action as a result of medial rotation of the femur during the last stage of extension, and to reverse this lock, popliteal muscles comes into action, and so does bilateral rotation of femur. So during the last stage of extension of the lower limb, this medial rotation, it produces locking action, quadriceps femoris. And to unlock this, popliteus muscle intervenes. So quadriceps is a large group of muscles that includes 4 prevailing muscles on the front of the thigh. It's the great extensor muscle of the knee, subdivided into 4 separate portions or heads, which have received distinctive names also. Rectus femoris occupies middle of the thigh, covering the other 3. Quadriceps muscle, and it origins on the ilium and named its straight course. Quadriceps. And the under quadriceps, this is the quadriceps femoris, main extensor of the knee. So rectus femoris, where another 3 lie deep to the rectus femoris and originate from the body of the femur, which they cover out the condyles. Cover out from the to the condyles. Okay. So this is the quadriceps muscle group, consists of 4 muscles: rectus femoris, vastus lateralis, intermedius, medialis. Vastus medialis, vastus, 3 vastus and 1 rectus femoris. Okay, so and quadriceps femoris is the main and only extensor of the knee. Okay. Okay, next question. Patient came into emergency department with flexion, adduction, internal rotation of hip. Flexion, adduction, and internal rotation. Diagnosis: internal rotation. Diagnosis will be posterior. External rotation, anterior. External rotation. Internal rotation, posterior. So most common type of hip dislocation in adults and children is posterior dislocation of hip. Usually this occurs in a road accident when someone seated in a car is thrown forwards, striking the knee against the dashboard. Another pattern of injury and position of hip at the time of injury is given. Like anterior dislocation of hip, hyperabduction plus extension. Here it was flexion and adduction. Flexion, adduction, internal rotation. External rotation, hyperabduction plus extension. Dislocation, this hip dislocation of hip can be classified into 5 types. Type 1, 2, 3, 4, 5. Type 1 is dislocation with or without minor fracture. Dislocation with single large fracture of posterior acetabulum rim type 2, dislocation of comminution of posterior acetabulum rim type 3, dislocation of fracture of acetabular floor type 4, and fracture of femoral head type 5. So these are the 5 types of dislocation of hip, and the classification is Thompson and Epstein classifications. Another classification is there, Stewart and Meaford. Okay, next question. 82-year-old female with necrotic head of femur and bilateral osteoarthritis. Next step of management. Cemented total hip replacement. Cemented total hip replacement will be the next step of management. Total hip replacement may be preferable in patients with acetabular damage, metastatic disease, or Paget's disease. So originally, the primary indication of total hip replacement was the alleviation of incapacitating pain in patients older than 65 years of age who could not be relieved sufficiently by non-surgical means, for whom the only surgical alternative was resection of hip joint. Therefore, it is mostly used for hip arthritis, avascular necrosis of femoral head, non-union of femoral head and or neck. So necrotic head of femur, female with necrotic head of femur and bilateral osteoarthritis. We will go for total hip replacement, cemented, not uncemented. Most common, next question. Most common organism causing osteomyelitis is Staphylococcus aureus, Streptococcus pneumoniae, Haemophilus influenza, and E. coli, Escherichia coli. And the answer will be Staphylococcus aureus. Osteomyelitis, most common organism. Another most common organism causing other conditions like osteomyelitis in open foot injury, osteomyelitis in HIV patients, osteomyelitis in case of animal bite, in case of human bite, all are given. Most common organism causing acute osteomyelitis is Staphylococcus aureus, whereas most common osteomyelitis in IV drug users is Pseudomonas, and osteomyelitis in open foot injury, Pseudomonas again. In HIV patient also Staphylococcus aureus. So this is about osteomyelitis, causative organism. Okay, next question is phelon means infection of epinicium, terminal pulp space, deep palmar abscess, and subcuticular space. So the answer is terminal pulp space. This is phelon. It is also called as whitlow. This is the infection of closed space of fingertip pulp. Infection occurring within these compartments can lead to abscess formation, edema, abscess formation, edema, rapid development of increased pressure in closed space, increased pressure, this increased pressure may compromise blood flow and lead to necrosis of the skin and pulp. This increased pressure compromise blood flow and blood flow compromise and necrosis of skin and pulp. Necrosis of skin and pulp. Phalanx are characterized by marked throbbing pain, tension, edema of the fingertip pulp. The phalanx should be incised in the area of maximum tenderness. The incision should not cross the distal interphalangeal joint to prevent the formation of flexion contractures at the DIP flexion crease. Complication may lead, as part of the complication, there may be osteomyelitis or tenosynovitis. So more commonly, osteomyelitis in phalanx occurs. So the management is incision in the area of maximum tenderness. That is the management. Most common area involved in tubercular spine, port spine. A tubercular spine is paradiscal, central, anterior involvement, appendical. Paradiscal. Paradiscal is the most common type of port spine or tubercular spine. It begins in metaphysis. This is the paradiscal. Paradiscal. In between two discs. It begins as metaphysis, erodes the cartilage, destroys the disc, resulting in narrowing of the disc space. This is number one. Number two, central type. Central. Midsection, beginning in the midsection of the body, getting softened after under gravity and muscle action, leading to compression, collapse, and bone deformation. Central type. Third type, anterior lesion. Lead to cortical bone destruction beneath the anterior longitudinal ligament. Anterior lesion or anterior involvement. Anterior involvement. You see, this is the anterior part. Spread of infection is in the subperiosteal and subligamentous planes, resulting in the loss of periosteal blood supply to the body with resultant collapse. Appendical type. Appendical type. The infection settles in the pedicle, laminar and articular process of the spinous process, and causes initial ballooning of the structure followed by destruction. Appendical type. So investigation of choice for the TB spine is MRI. And the spinal TB is always secondary to primary lesion and occurs due to hematogenous spread. So these are the four types. These are the four types of port spine. The most common sequel of tubercular spondylitis is fibrous ankylosis, bony ankylosis, pathological dislocation, and chronic osteomyelitis. And the answer is bony ankylosis, most common sequel of tubercular spondylitis. Tubercular spondylitis is the most commonly localized in thoracic portion of the spine. The infection coming from primary site spreads from two adjacent vertebrae into the adjoining intervertebral disc space. So infection coming from primary site, that is lungs, primary tuberculosis, obviously lungs. It spreads from two adjacent vertebrae into the adjoining intervertebral disc space. And if one vertebra is affected, the disc is normal. But if two are involved, the disc, which is avascular, cannot receive nutrients and collapses. The disc tissue dies and is broken down by caseation. Leading to vertebral narrowing, eventually to vertebral collapse, bony ankylosis, and spinal damage. So we choose bony ankylosis as answer. Actual late complications of tubercular spondylitis is vertebral collapse resulting in kyphosis, spinal cord compression, sinus formation, paraplegia. Most common cause of bony ankylosis is septic arthritis. Most common cause of bony ankylosis, and then TB spine. Most common presenting age of Ewing sarcoma, second decade. Most common presenting age of Ewing sarcoma. Ewing sarcoma is generally a lesion of children and adolescents occurring most commonly in the first 2 decades with a peak incidence in the second decades. It's highly malignant, undifferentiated peripheral primitive neuroectodermal tumor. Neuroectodermal tumor. And most common site is diaphysis of femur. Very, very important. All these facts are very important. Other sites are given here in the picture. An X-ray reveals laminated periosteal new bone formation known as very important onion peel appearance. Ewing sarcoma, the famous onion peel appearance. Very important onion peel appearance is associated with Ewing sarcoma. What is this appearance? Because periosteal new bone formation occurs. Bone formation. Bone formation occurs. Which of the following is seen in Bottonier's deformity? Extension of PIP and DIP, proximal interphalanges and distal interphalangeal joints, flexion of PIP and DIP. So extension of PIP, DIP, flexion of PIP, DIP. Flexion contracture of PIP and extension of DIP. Flexion of DIP and extension of PIP. And the answer is flexion contracture of PIP, proximal interphalangeal joint is flexed, while distal interphalangeal joint is extended. So first flexion, first IP means interphalangeal joint is flexed. Next, extended. Distal one is extended. Simple. First flexion, then the extension. First one is flexed, second one is extended. That is Bottonier's deformity. Other deformity like jet deformity, swan neck deformity are all there. Jet deformity, swan neck deformity, wind sweep deformities. Okay. So next question: injury to cervical nerves C5 and 6 causes Erb's paralysis, Klumpke's paralysis, Horner and central cord. Erb's paralysis, injury to cervical C5 and C6. Erb's paralysis, and these are all the features of Erb's paralysis. and this is Horner. This is Horner. In Horner syndrome, what happens? Pancoast in arms paralysis, first of all, it's a paralysis of arm caused by injury to the upper group of arm's main nerve, specifically severing the upper trunk of C5 and C6 nerves. Arms paralysis, C5 to C6. While Horner, seen with Pancoast tumor presence with ptosis, meiosis, in ophthalmos, and anhydrosis, loss of ciliospinal reflex. So this is quite different. And clump case involves 8 cervical vertebra and first thoracic vertebra. Horner, clump case, central cord syndrome. Central cord, it is found it occurs after hyperextension injury in an individual with long-standing cervical spondylosis. So already long-standing spondylosis was present, and on that hyperextension injury occurred, presenting with the feature of corticospinal pathway. That is central cord syndrome. And these are the features of Erb's palsy, like lumbar scoliosis, like bird winging of the affected scapula, cervical scoliosis. There can be many features actually. Shoulder rotated forward, affected arm diminished in length and girth, muscle atrophy of the affected arm. And weighted tip deformity of the affected wrist, weighted tip deformity. So, as C5 and C6 nerves, upper trunk nerve, upper C5 to C6 upper trunk of brachial plexus is affected, the nerve supply coming out from nerve branches or nerves that are coming out from that C5 and C6 so the nerves coming out from C5 and C6 trunk are all affected, and their features are manifested here. Okay. The condition in which there is anterior posterior displacement of vertebra in relation to the vertebra below, spondylosis, spondylitis, spondylolisthesis, spondylolysis. And the answer will be spondylolisthesis. So condition in which there is an anterior or posterior displacement of vertebra with the relation to the vertebra below. Spondylolisthesis is an anterior or posterior displacement of vertebra or the vertebral column in relation to the vertebral below. Spondylolysis is stress fracture in pars interarticularis, while spondylolisthesis is a stress fracture and sliding of the vertebra. So basically, why anterior and posterior displacement? What is the meaning of this? Sliding of the vertebra. Sliding of vertebra occurs here. Book test or cart test is done for which nerve injury? Radial, ulnar, median, tibial. So cart test or book test, palmar interossei are adductors tested by asking the patient to hold a card between the extended fingers and assess the resistance against pulling. It is used for verification of ulnar nerve injury. Ulnar nerve injury. And book test or Froment sign to test adductor policies asks the patient to grasp a book or card between extended thumb and index finger. And ulnar nerve palsy patient tries to grasp the book by flexing the interphalangeal joint of the thumb. Also this. Okay, so these two, card or book test. Cock-up splint is used in the paralysis of cock-up splint is used in the paralysis of ulnar, radial nerve, median nerve, sciatic nerve injury. Radial nerve. So cock-up splint is used in the paralysis of radial nerve. Other splints are given like knuckle bender splint is used in ulnar. Aeroplane splint in brachial plexus, Dennis Brown splint, CTV, Bowler's Brown splint, fracture femur, turnbuckle splint, VIC. So all the splints name and their corresponding conditions in which they are used is very important. In orthopedics, you must go through this table and must remember the splints that are used in each of these respective nerve injuries or conditions. Okay. Neuropraxia is a condition characterized by divisions of nerve sheath, division of axon, division of nerve fibers, physiological block. Neuropraxia is a condition characterized by physiological blocks. Now there are three patterns of nerve injury. Three patterns of nerve injury. One is reversible physiological nerve conduction block. Basically,